Thank you so much. I've listened carefully. Since the commissioner stood up, let me also stand up in respect to the audience. Panelists, you've excited my heart, and I'm very humbled for the feedback you've given us. It is very challenging, but also soul-touching. When the government of Uganda and Tasso were telling us about CLM at the board, we had a series of questions and asked a lot of questions to them because we wanted to be convinced before we could give them the money. But finally I'm hearing by myself, who was even very hard to allocate any money for that component. I think I'm one of the hardest men to convince on the CCM board. Once you convince me, you can convince everyone. You convince me, you can convince everyone. But I ask very hard questions, and so many times they say, Muzei, leave us alone. But finally I'm here and I'm hearing these testimonies. They are very encouraging. We can give this team a hand of applause. And all of you there, you've done a lot of great things because these are just voices from yourselves. When someone was asked to define and explain the meaning of CLM, me, I knew just CLM is community-led monitoring. And that's where I ended. But somebody was able to dissect. This means that you are conceiving the right information, which gives us confidence that we are sowing on the right soil. And so with that, we know we shall all achieve. Previously, Minister of Health and civil society, we were looking at each other's cause, or co-wives, not so. Target groups who are also providing what? Services. Most especially when the Monipa executive director was speaking, I looked at most of our spiritual leaders in town, in the city here. We will just say receive, and you get received and you get delivered. We need to also understand those services. How do they operate? Praise God. We need to understand. Because there are people who are told to testify that they have been healed of HIV, when in reality, there is none. They have not been retested to confirm. So, I think, Commission, that's very critical. We shall encourage Udha, Tasso, and the people who are working on the CLM framework to include such ideas, the traditional healers, those traditional healers who even promote more infections than healing. Because we used to have somebody in this region called Wanumba Gwenimba. Was it like that? Anumba Gwenimba or Wandumba Gwenimba? Mulumba Akulimba. Okay. Then we had someone called Dr. Susan Susanna. So we realized that Dr. Susanna, who used to be a woman, by the time she died, did she die? So when she died, she became a man. Yes. When she died, we went to check. The woman has turned out into a man. When she was sick. Okay, that's when you discover that she's a woman, a man. Okay. You can imagine some things. So yet they are service providers, and very many of our people go there. So we need to capture some of this so that we orient. There is a program we handled under TBS. When the ministry policy was wiping them out, then we had a lot of engagement with the Ministry of Health officials as an organization, and we were asking, are you killing them? Because if you say wipe out TBS, and they are human beings who are living in their homes, you did not select them to be TBS. They are naturally what? TBS, and the people believe in them. How can we address the problem than just passing the policy? So we were given an opportunity to have a pilot where we made sure that all TBAs are registered and then aligned through to change the understanding, and they were called TBRAs. So we say this is a modern name. It's like a Christian name for you. TBRAs, traditional birth referral attendants. And then we gave them phones, and we gave the motorbike ambulances to those communities. So they would call the motorbike when a mother comes. Then the motorbike comes and carries them to the facility. So we worked with the facility health workers, and they said when this mother comes, give her opportunity to make a choice. Should she be delivered by the TBA she has come with, or be delivered by the midwife? But all this should be under supervision by the professional midwife. So that thing improved the indicators on maternal health in this region. So we believe that, Doctor, what you are saying has already worked somewhere, and we believe that when we integrate this kind of idea, it will take us to another level. Because these traditional healers are very, very powerful. And then we also wanted to understand, you work with the government facilities, but in the city here, we have more private facilities. Of health workers, but there is a very high level of negative attitude by the communities.
facilities is that they know that they are there. Gaps in the government
Bugisu region. We can give her a hand clap as she's joining us.
Good afternoon, ladies and gentlemen. Damali Waiswa are my names. And just to allude to what Jackson has introduced, I oversee TB and leprosy activities in the regions of Bugisu and Bokedi. I feel indebted that I'm part of this forum this afternoon. Actually, one of the community members who takes care of people affected and infected by tuberculosis. And I'm happy that we are now a voice being co-opted so that we see the improvement of our own health as the TB family. So members, I'm going to invite, looking at the agenda, we are looking at, this is panel 3, and we want to hear from our respective districts. So it's about the responses of our different districts. We want to appreciate what we think being able to address as districts, and we'll straight away be able to appreciate what we think we are not able to handle as districts, and probably the regional and national levels can handle. So join me, welcome the DHO Tororo, the DHO Mbale City. We can have the Biostat Bukwa. and we'll also have a representative from Busia, the CDO from Busia. You're most welcome. Dr. Jagiri, you're most welcome. Well.
midwives. So those are some of the things which dictate our deployment formulas. And then overall, our staffing levels in Toro district is at 33%. That is way below what we need to provide services. And if our people appreciated, they would probably be with us in the problems we are facing. But when you come to Tororo, you can interact with 4 facilities where we have a single staff, a single qualified staff as a service provider. So this person is not supposed to fall sick, it's not supposed to visit children, it's not supposed to go for leave, because there's only one. And this can easily translate into a waiting time problem. Because even if you have 3 qualified staffs in a facility where we have several engagements on a daily basis, you realize that they are not thick enough on the ground to cover. For instance, actually for me, when I go to the health centers, I try to avoid the clinical areas. I look around the other bits more, because you find the nurse is seated on a register as wide as that table you are seated on, writing from one extreme end to the next for one patient. Just recording the details of a patient alone on that register, from address to sex to age to NIN to next of kin to suspect to what. By the time you reach the end, your head is boiling. And this contributes to the long waiting time we're talking about. But then again, I also found out when I was at the health center that there are work mechanisms that can be modified to improve some of these things. For instance, I found out that some nurses find it convenient to batch patients. So you find they want to record for 10 patients. Do everything for 10 patients first. Then you start calling. Onyango, Panado 2x3. Mugonyi, Amoxi, so that you send away that batch. So that method is convenient for the health workers because it gives you some security in terms of being able to see off a group of people, other than trying to work on one person from picking a book from the clinician, recording in the book, packing the medicine, instructing the patient, and see them off. Then you start on another. But the batching helps them to see off a group together and sure you have that group, but also it causes some patients who came later or earlier to wait for those who came later, and they live together. So those are the mechanisms in the facilities which create this long waiting time. But what has happened is that within facilities, we ask people to be innovative. Of course, we can't have a uniform method of doing some of these things depending on the disparities in the staffing levels. And so we need to be innovative and try to serve our people well whenever these issues arise. The biggest challenge is attracting wage. I don't know where a wage comes from, but it's everything that wage. I remember this last financial year, we actually had wage, but you have to get clearance from public service to recruit. So even where you have wage, there is clearance. I don't know why they give you wage, which they think you cannot use. So there are very many complications around these things, human resource and the operations of the human resource when we acquire them, that need some soul searching and a bit of innovativeness, and sometimes we may need proactiveness to get some things done. I wonder what would happen if, say, I used wage without clearance. I don't know what would happen to me, but I'm imagining that it's one of those Balaam-like approaches we might have to engage so that we get things moving. Thank you.
Yeah, thank you so much, DHO Tororo. We all appreciate that the findings were real. As he tried to appreciate those that resonate most in the district, he has actually touched on all of them. Doctor, we want to understand issues of organized absenteeism at the different health facilities that probably facilitate the low staffing at a given day. That instead of the 3 midwives working on a given day, each one handles a week in a month. Doesn't that affect the quality of care in those respective facilities?
Thank you. I want to say that organized absenteeism is a reality in our health facilities, and it is part of the, I think, the innovations that our staffs are trying to use to remain relevant, but also it translates into what you have just talked about, long waiting time, because you are as few as 3, but you want to try and remain functional as a person. Many of our health workers are young, they are yearning for promotions, they are yearning for improvement in career, they are not settled. So sometimes they do these things to try and cover up or create opportunity for them to be off station, to do a few other things so that they progress. But in the end, they affect us. But this is something that we are really coming hard on. As a district, we expect that with the current crop of leadership we have, we shall do adequate monitoring to establish who is where at what time, so that we help our people to remain relevant. And with the coming of HCM, when we finally get there, I know that some of these things will have to die a natural death, because with that organized absenteeism, you may not achieve the 21 days to be able to achieve a salaried working period. So we hope that these are things we shall come over with time, but we need the support of everybody to ensure that our people remain grounded and available.
Yeah, thank you so much, DHO. May we listen in from the DHO Mbale City? We appreciate that we are all out to see that we improve the quality of care for our patients. But communities continue to raise concerns about their own experience, the staff attitude, like many have already alluded to, and the quality of care. As Mbale City, what strategies are you implementing to improve the quality and the responsiveness of health services? Over to you, Dr. Mgonyi.
Thank you, Madam Moderator. Let me recognize the presence of our Commissioner, Minister of Health. I don't know what time he arrived in Mbale, because we were with him in a meeting till late evening in Hotel Africana yesterday. But I appreciate that he's here with us. I appreciate the presence of all our directors of our CSOs and largely the other stakeholders who are on their listening side, the cows, the other colleagues, the community members, they're all our stakeholders. We are in all this together because today I'm a DHO, I'm a commissioner, but at any one point I'll be in need of these services. That's how we should all take it, because we are all potential patients and potential beneficiaries of these services. In Mbale City per se, I didn't have the privilege of listening to the comments from my stakeholders in the city, but as you highlighted, the community responsiveness in terms of issues of the quality of services. Of course, in the city, of course, Mbale City is a major referral point for Bugisu, Bukedi, Sebei region, and part of Teso, even part of Busoga. And all these regions, patients, I don't know why they have so much trust in the services in the city. You may find they have referred from a hospital somewhere, they come here in the city, they go to the regional referral, they find even the patients are sleeping under beds of others, so they rush to even some of my health center tools. And how they manage, I even don't know, but they manage and they go back satisfied. So in the city, UBOS gives us a population of 360,000 people. That's the night population. But during the day, we have well over 1 million people, and these are people who need services. Much as they are planned for us, the other number, in terms of human resource, medical supplies and commodities, even including infrastructure, we still have to attend to the other 1 million who are coming to do business here, who are coming for school, who are coming for other social amenities. So that said, if you go to my typical facilities, name it, whichever facility, you'll find basically a market day. And with a fixed number of staff, in the city we've tried to, as much as possible, to increase the staffing levels. As we are now, we're about to 45%. But because of the overwhelming need, basically all my staff are always complaining of back pain, others work till they even collapse. And the whole situation has been made worse with the coming in of the electronic systems, whereby people can see patients, but somewhere they get a deadlock because they cannot progress, because the system either freezed or even internet goes off, even the power is even off. And the guidance from the ministries, we have to use the system. So we've had to explain and explain, explain to somebody who is dissatisfied because of the system. Sometimes I even tell them just leave the system aside and we move forward. But these are situational issues. They are not issues caused by any of us as stakeholders, but of course, with the time we shall be there. About the quality of services, I think we provide. When you're not providing a good quality of service, people don't come. But when you go there, we're even overwhelmed. You build a maternity ward, within a few months, it is not even enough to provide the services that you envisaged before. I think those are the brief comments I can give Madam Damali. Thank you.
Yeah, thank you so much, Doctor. Minister of Health has endeavored to hear from the communities. We are now in for the routine client satisfaction feedback interviews. The uptake of these interviews is a little low across facilities, meaning that probably the health workers are not interested understanding whether the clients are satisfied or not even satisfied with the services we offer. And now that we are talking about the quality of care, we are meant to appreciate what the clients have spoken to, take action, and even follow up. What is your feel in some of the facilities within Mbale City?
Yeah, thank you, Madam Moderator. The issues of client satisfaction interviews. Initially, it was the staff were basically scared. And if you talked about the clients giving an interview, they could simply get scared to be like they are reporting them. But then I told them that if you are indeed doing a good thing, you should even be happy that they are reporting on you, unless if there is something you are hiding. It is a new change which has come on board, and which we are trying to convince our staff such that they fully embrace it. And when you go to all my facilities, we have displayed the barcode. It's called the QR code.
Yes.
And for those who may not be having smartphones, we've had to print copies such that they can fill them. Then we get some neutral person to punch them in the system. And even at my office, when you come, whoever client comes, I request them to fill that client satisfaction code as well, to lead by example. And I know a number of facilities are in green. I think we have Ufumbo, we have Namakwekwe, and I believe others will come on board such that we get a true picture of what our clients are feeling out there. Thank you.
Yeah, thank you so much. And just as you hand over the mic to another colleague, the role of the support staffs in the different facilities. Are we giving them our tasks as the technical staff to take over the health system, or we are just task sharing? Are we task shifting or task sharing?
I think this is something which, you know, when you have when you're employed by any organization, including government, we have what you call a job description. There's a job description for a CHO like me, job description for a CHO maternal and a CHO environment. So easy for doctors, nurses, biostats, HIAs, even askaris and porters and cleaners, not to forget. But where you find somebody jumping, but me as a doctor, I can even do the work of a cleaner if the situation demands. But sometimes it's almost impossible to do the reverse, if not risky, to you yourself, including the clients you are pretending to serve. So as a city, we always encourage our staff to keep by our job descriptions. But of course, in certain situations, the bigger person can do the small work, but not the reverse. That's how I handle it in the city. Thank you.
Yeah, thank you so much, Dr. Mugonyi. Do we have the CDO Busia? Yes, you're most welcome.
Thank you.
We just wanted to appreciate, how is your district strengthening the community participation, the feedback mechanisms, and the social accountability within the health system?
Yeah, thank you.